As I did mention, I am recording the session, so it will be out later on our Zoom, or excuse me, on our YouTube channel, and we'll push it out on social media. So if you have anyone that wants to watch it later on, they are more than welcome to do so. For tonight's presentation, our Missouri State University, or Mizzou healthcare team has put a lot of work into recording the event ahead of time, so all of their folks could participate, and they cover a topic each. And then at the end, we'll take time for questions. So that gives a few more folks time to join. But if you have questions, you can put them in the Q&A area of the chat box or the Q&A area, or you can use the chat itself, whichever you're more comfortable with. I'll be moderating that. And then again, as we get towards the evening into the presentation, our care team from the adult and children's side is joining us live. So they'll be able to answer questions live, but the program itself is pre-recorded. So thank you all for joining us. I'm going to turn off my screen, and if you want to watch the video, play along. I did a test run earlier, but if you want to put in the chat, if for some reason it's not working, please let me know. But thanks for joining us tonight.
Good evening. Welcome to the Cystic Fibrosis Community Chat, presented by the University of Missouri Healthcare System. Our physicians include Dr. James Acton, our program director, Dr. Zachary Holliday on the adult side, and Dr. Morgan Green on the adult side, and Dr. Rebecca Neville. Our nurse coordinators are Connie Fenton with the PEDS team and Haley Hill with the adult. Our team members for both PEDS and adult are Natalie Harris, our respiratory therapist, Alex Majors, our pharmacist, and Jill Graneman, our dietitian. Our CF social workers are Keisha Nelson on the PEDS team and Heather Blumberg on the adult team.
I'm Heather Blumberg, adult cystic fibrosis social worker and mental health coordinator at University of Missouri Healthcare. A year ago, by this point in 2021, we were expecting to be in more of a new normal, and yet the pandemic continues to disrupt daily lives as the Delta variant of COVID-19 sweeps through the country. One of the biggest sources of stress is uncertainty and unpredictability. The rate of stress-related disorders has also started to rise again amid ongoing unpredictability. Among this, we have heightened levels of anxiety and depression. This can impact every part of our lives, including our ability to accomplish basic tasks, maintain our relationships, and even affect our bodies. No one can avoid the unexpected, but there are certain steps you can do to help better face life's uncertainties. Being kind to yourself is one of the first steps. Some people are better at dealing with uncertainties than others, so don't beat yourself up if your tolerance for unpredictability is lower than a friend's. Remind yourself that it might take time for the stressful situation to resolve, and be patient with yourself in the meantime. Why is it so hard to be kind to myself? It sounds like a relatively simple concept, yet for many of us, being kind to ourselves, particularly when we face failure, can seem downright impossible. One of the reasons for this is because society has conditioned us to focus on self-esteem rather than self-compassion. When we are able to connect what's human about ourselves and recognize our strengths and weaknesses, we are able to take care of our health better and motivate ourselves more long-term. Reflecting on past successes, chances are you've overcome stressful events in the past and you survived. Give yourself credit. Reflect on what you did during that event that was helpful and what you might like to do differently this time. Develop new skills. When life is relatively calm, make a point to try things outside your comfort zone. From standing up to a difficult boss, to trying a new sport, taking risks help you develop confidence and skills that come in handy when life veers off course. Limit exposure to news. When we're stressed about something, it can be hard to look away, but compulsively checking the news only keeps you wound up. Try to limit your check-ins and avoid the news during vulnerable times of day, such as right before bedtime. Avoid dwelling on things you can't control. This is the worry tree. It allows you to ask yourself questions about your worry to determine if this is a real problem or a hypothetical worry. By going through the questions, you can give yourself permission to move to the next step instead of only ruminating. Taking your own advice, ask yourself, if a friend came to me with this worry, what would I tell her or him? Imagining your situation from the outside can often provide perspective and fresh ideas. Engaging in self-care. Don't let stress derail your healthy routines. Make efforts to eat well, exercise, and get enough sleep. Many people find stress release in practices such as yoga and meditation. These are some examples of self-care that you may be doing already or could add to your routine. Some of them are making sure that you are showering regularly, going outside in nature, taking a walk, seeking support from those you trust. Many people isolate themselves when they're stressed or worried, but social support is important, so reach out to family and friends. Control what you can. Focus on the things that are within your control, even if it's as simple as weekly meal planning or laying out your clothes the night before a stressful day. Establish routines to give your days and weeks some comforting structure. Having to deal with negative thoughts is part of everyday life. But remember that thoughts are just thoughts and not reality. Taking control of your behavior, asking for help. Sometimes problems seem like they are impossible to solve for many different reasons. Sometimes we are not even fully aware a problem is building up. We just know something is wrong. If you're having trouble managing stress and coping with uncertainty on your own, ask for help. The numbers are Substance Abuse and Mental Health Helpline, Suicide Prevention Lifeline, and National Domestic Violence Hotline are the numbers listed below. While the situation that we are currently in is critical, it is not hopeless. Even before the COVID-19 pandemic turns the corner, we need to invest in helping ourselves recover mentally and physically, which will make us stronger for the future.
Hi, my name is Dr. Rebecca Neville, and I will be presenting our work on the impact of the SARS-CoV-2 pandemic and a food pantry on food insecurity in our Pediatric Cystic Fibrosis Center. This work will also be presented at the North American Cystic Fibrosis Conference this year. The background of the study is that food insecurity, as defined by the U.S. Department of Agriculture, is a household-level economic and social condition of limited or uncertain access to adequate food, and the Missouri Hunger Atlas reports that 12.8% of homes in Missouri are considered food insecure. We know that the caloric needs of children with cystic fibrosis are higher than those without, and the recent global SARS-CoV-2 pandemic has resulted in additional financial stressors for families. We had 3 hypotheses for this study. The first is that the SARS-CoV-2 pandemic will affect the rate of food insecurity in our CF population. Second, children who are provided with access to adequate nutrition through an in-clinic cystic fibrosis pantry with high calorie, high fat, high salt, nutritious and shelf-stable foods and supplements will demonstrate a decrease in reported food insecurity. And third, after implementation of an in-clinic CF food pantry, there will be a decrease in percent of patients with at-risk nutritional status, that is, weight for length or BMI percentile less than the 50th. Regarding methods and results for this study, a 2-question food insecurity survey was completed anonymously within our CF clinic. Families were screened both before and 6 months after onset of the SARS-CoV-2 pandemic, and then an in-clinic CF food pantry was established, and families were re-screened 6 to 12 months after the food pantry intervention. As you can see in Figure 1 on the right, before and after onset of the SARS-CoV-2 pandemic, the rate of food insecurity in our CF clinic was approximately 50%. Following initiation of the CF food pantry, this decreased to 16%, which was a statistically significant improvement in our food security status. Additional findings regarding food insecurity include that approximately half of families that were surveyed who were found to be food insecure had access to other food assistance programs, and a third of families reported that the COVID or SARS-CoV-2 pandemic affected their food security status. Overall, 75% of families reported that the food pantry did improve their food security status. Regarding nutritional status, at-risk nutritional status, or weight for length / BMI percentile less than the 50th, was determined before onset of the SARS-CoV-2 pandemic, 6 months after onset of the SARS-CoV-2 pandemic, and then 6 months after initiation of our in-clinic CF food pantry. As you can see in Figure 2, the percent of patients with at-risk nutritional status decreased from approximately 27% after onset of the SARS-CoV-2 pandemic down to 13% after our intervention of an in-clinic CF food pantry. This also was statistically significant. In conclusion, food insecurity is a challenge for about half of families in our cystic fibrosis center, both before and after onset of the global SARS-CoV-2 pandemic. A third of families did report that viral pandemic affected their food security. Secondly, although nutritional support programs are available nationally, only half of those families who were found to be food insecure in our center reported access to food assistance programs. This may provide opportunity for future intervention to improve food security status for these high-risk patients. Third, following implementation of an in-clinic food pantry with high-calorie, nutritious foods and supplements, there was a reduction in families screening positive for food insecurity, a decrease in the percent of patients with at-risk nutritional status, and a majority of surveyed families reporting that the food pantry improved their food security.
Hi, my name is Jill Granneman. I am the CF dietitian for both the peds and adult side here at the University of Missouri. I'm excited to be with you today to discuss some of the challenges we've seen with Trikafta in the realm of nutrition and weight gain. We know that there's been so many great benefits to starting on Trikafta, improving lung function, less sickness and hospitalizations, improved digestion, and all of these great benefits have been wonderful, but we've also run into some challenges with weight gain and difficulties with weight management at our center. Historically, weight-related concerns have been limited to how to successfully gain weight. But today I want to talk about how Trikafta encourages weight gain, some of the concerns with excess weight gain, and some ideas on what to do if you're currently struggling with your weight while taking Trikafta. So how exactly does Trikafta help with weight gain? Primarily what we know at present is that Trikafta helps with weight gain in two main ways, via digestion and absorption of calories and by decreasing energy expenditure via improved lung function. So how does Trikafta help with digestion and absorption? We know that Trikafta can help increase the flow of bicarbonate via the pancreas. This in turn acts as an antacid in the small intestine, and it helps your enzymes work more effectively. So better absorption of calories because of better enzymes efficacy and less calories lost in the stool. Secondly, Trikafta can lead to better digestion, which we know it can help reduce the amount of abdominal discomfort you have. And when you feel better, you eat more. So we know that increased appetite can also lead to weight gain. So we know that Trikafta can greatly improve lung function. And what this actually can do is help lower your basal metabolic rate. This is how much energy your body will burn at rest. Historically, BMRs for CF patients are about 1.3 to 1.5 times as higher than the average non-CF individual. So improving our lung function can help bring our basal metabolic rate down, and that means we'll require less calories at rest. So what are the concerns with excess weight gain? We know that our lung function overall can be reduced when our BMIs are greater than 30. We know that some of our patients are seeing increased blood pressure, and we know that some other possible complications could include high triglycerides, high cholesterol, and possible concerns overall with cardiovascular health. So we've seen such varied responses with Trikafta. Some of our patients needed to gain weight when they started on Trikafta, and that has been helpful because they've been able to gain the weight they needed to, and they've improved their lung function, and it's been great. Other patients of ours have gained weight and then had trouble with that weight gain continuing and trying to put the brakes on it. And we also have to think about each of our CF patients as individuals. So, you have different health concerns. Some of you have diabetes, some of you have liver disease, and you're living different lives, right? So we have to remember that we have to individualize our nutrition plans for each one of you. You have varied metabolisms, varied activity levels. Some of you work desk jobs. Some of you work very highly active jobs, such as construction. All of you have different eating styles. Some of you, do you skip breakfast? Some of you, do you eat, mini meals all day or snack more often? And of course, we have to talk about, what are your different tastes? Do you like vegetables? Do you like fruits? What kinds of different things do you like to eat? And another good thing to remember is, do you have a good support network at home? Do you have kids? Do you have adequate help with your kids so that you can work out or be physically active? Do you have good accountability in your life? Do you have friends that you can count on or reach out to help you develop and maintain a healthy lifestyle? All these things are good for your dietitian to know. They can help you create a individualized nutrition plan that's going to work better for you. So some of the challenges we have to consider with eating habits, it's a big mental shift. The traditional CF diet, of course, is high in fat and calories, and then trying to change that to a diet more moderate in fat and calories, that can be kind of a big shift for some of our patients. And then another thing to consider is, are you eating according to your hunger cues? Do you know what that feels like in your stomach? True stomach hunger, what does that feel like? Are you able to sense that? Versus, do you feel like you're eating according to the clock? It's noon, so it's time for lunch, versus waiting on your hunger. Because in the past, you might have had to eat according to the clock or a very set schedule because you were relying on all of those calories to come in to maintain your weight. So that's another thing to kind of consider. Another huge one we have to worry about today too is the allure of fad diets in our world, right? They're everywhere. You can find low carb, high carb, eating at certain times a day. Everyone will try to sell you on a fad diet, but we know that research shows that fad diets don't work. They're not sustainable. No one stays on them long term, and it also can really backfire and cause more problems with your weight doing these fad diets. So it really is important. It's really important to work with your dietitian come up with some healthy, sustainable eating strategies that you can continue long term, and that will really make a difference in your ability to maintain a healthy body weight. And then I kind of like to always talk about the 80-20 rule. Like, we're not going to be 100% perfect with our diets. 80% of the time we try to make, good choices with food, nutrient-dense choices such as, fruits and vegetables, whole grains, legumes. But then 20% of the time we're going to enjoy, our food. And even if it's, if you notice like, okay, 50-50, 50% of the time I am making good, decent choices, and 50% of the time I'm not. Just aiming to, shift your focus to, okay, 60% of the time I'm going to try to, eat an apple before my lunch or eat it with my lunch, instead of just, not making effort. Every little bit counts, really does. So lastly, I'm going to leave you with a few practical tips. We already talked about eating according to hunger cues, sensing true stomach hunger, and eating when you're hungry versus just eating whenever. Another thing too to talk about too here is emotional eating. That's a big one. Just in the general population too, we find ourselves eating when we're frustrated or angry or bored or upset. It can be a stress reliever, and we can reach for food for those reasons. I would encourage you to reach out to your mental health coordinator, your social worker. They can help. Use your resources. It is difficult to, when you get in a pattern of emotional eating, to shift towards healthy coping strategies, going for a walk or, calling a friend. What are you really wanting when you're reaching for food for emotional reasons? Trying to meet the need instead of that emotional need, instead of using food to cope. Here's a couple of nutrition tips. Sugar sweetened beverages, they pack a lot of calories. So if you're trying to maintain a healthy weight or lose some weight, you can try limiting those beverages to once a day, or even cutting them out altogether, looking for non-calorie beverages to try, such as tea, or coffee or something like that. And then another good tip is to try starting each meal with a salad or a vegetable. What it will do is take up space in your stomach. Even if you want to eat a large apple, anything that is a lower calorie dense food is going to take up room in your stomach and leave less room for the higher calorie dense foods. Another good tip is to incorporate vegetables into your pasta, soups, and main dishes. So like if you make spaghetti, chopping up zucchini, they have really cool like spiralized things you can make zucchini noodles out of, and you can add that into your pasta, and a lot of times your kids aren't even going to notice that they're there, and you might not even notice, especially when you add sauce. It's a way to kind of lower the calorie density of your overall meal. And then just, trying to incorporate them as much as possible into all of your foods. And then between meals, when you get hungry, carrying fresh fruit in your bag with you, being prepared, when you go to work, having a bag of, of some fruits, vegetables, different, a little bit lower calorie snacks to have when you get hungry between meals. And then regular exercise, of course. We know that exercise can help improve your lung function, can improve your mental health, can improve your overall quality of life. My recommendation is to find something that you really enjoy doing, because let's face it, we're not going to continue doing it if we don't enjoy it. So, if walking is something that's enjoyable, then, wear a pedometer, check and see where you're at stepwise, and just kind of incrementally try to increase the amount of steps you get in a regular day. Overall, those are kind of my tips for trying to improve your weight status or just maintain your current weight. Lastly, I wanted to share this quote with you from James Clear, the author of Atomic Habits. It's a really great book. Check it out. All big things come from small beginnings. The seed of every habit is a single tiny decision. So we make these little tiny decisions all day, every day. So in terms of nutrition, maintaining a healthy weight, tiny decisions, you know, what can you do what are some things you can do to try to incorporate healthy foods into your diet if you're not doing that already? Think of little strategies you can make along the way that they really do add up. And over time, it can really change the trajectory of your nutritional status and your weight. So thank you very much for your time. It was a pleasure being with you today.
Thank you for tuning in this evening. My name is Alex, and I'm a pharmacist with the care teams. I just wanted to take this opportunity to provide a quick COVID-19 vaccine update for people with CF. The CF Foundation and all of us on your care team support vaccination for all people with CF and their family members who are eligible. All 3 authorized vaccines have been shown to be safe and effective, especially at preventing hospitalizations and death. Side effects have been rare and minor for most people, and we encourage you to talk with any member of your care team if you have any questions or concerns about the vaccine. There are currently 3 vaccines available: Pfizer for ages 12 and up, and Moderna and Johnson & Johnson for ages 18 and up. Pfizer and Moderna are mRNA vaccines, which means they're essentially made of 4 things: water, salt, lipids, and messenger RNA. The messenger RNA carries the code for the spike protein. So then our immune system is able to respond and make antibodies, which will protect us if we encounter the SARS-CoV-2 or the COVID-19 virus. Johnson & Johnson is a viral vector vaccine, which contains the spike protein inside of a non-replicating adenovirus vector. So as of this recording on October 8th, currently the Pfizer vaccine is only approved for ages 12 and up. But there's an FDA meeting that will occur on October 26th to make recommendations on children ages 5 to 11 years. So it's possible that we may have another tool to protect this age population by October 26th. You may ask, what about booster vaccines? So currently, the booster vaccine is available if it's been more than 6 months since your second dose of the Pfizer vaccine and if you meet the current criteria. So if your age is 65 and older and living in a long-term care facility, if your age is 18 to 64 and have an underlying medical condition such as CF, or if you have a job that increases your risk of exposure to COVID-19, such as working in healthcare. We also encourage people who are immunocompromised post-transplant and have received an mRNA vaccine to talk with your transplant or care team about receiving an additional dose. There are a lot of myths out there regarding COVID-19 vaccines, so I just wanted to talk about a couple of the most common ones. There's a myth out there that the vaccines don't work because there are still people who have had the vaccine who are in the hospital. And we know that breakthrough infections are possible, but these are generally less severe. If you look at a snapshot of patients that are currently admitted at University Hospital, so there's patients on ventilators, there's 1 that's vaccinated and 8 that are unvaccinated. In our ICU patients, there's 1 that's vaccinated and 17 unvaccinated. So 97% of deaths from COVID-19 are occurring in unvaccinated people. You may think that the vaccines were developed too quickly and aren't safe. There were years of basic science research for other vaccines that laid the groundwork for these vaccines. There was an overlap of phase 1, 2, and 3 studies, and the enrollment for these studies occurred very quickly because people were so motivated to find a vaccine that protected them against COVID. It was also nice because the drug manufacturers were able to start making these vaccines during the clinical trials so that they would be available if the studies proved that they were safe and effective. And the FDA and the CDC also prioritized this review process to get these out to the public so quickly. Another myth out there is that we don't know what side effects to expect from the vaccine. From the millions of people who have already received the vaccine, we know that the most common reaction is soreness at the injection site, and people may also experience fatigue, headache, muscle aches, or joint aches, and that's really a sign that your immune system is responding appropriately and will help to protect you against the virus. If you're interested in finding a COVID-19 vaccine near you, there are a couple national resources and also local resources for Missouri. So if you have any questions, be sure to reach out and let us know if we can help. But overall, we know that vaccines have not caused CF pulmonary exacerbations. They've generally been well tolerated in folks with CF, just as in the general population. And we've talked to a lot of people that are relieved after they receive the vaccination because they know they've got an additional layer of protection. If you have any questions, don't hesitate to reach out to any of us on your care team. Thank you. Thank you for tuning in this evening. My name is Alex, and I'm a pharmacist with the care teams. I just wanted to take this opportunity to provide a quick COVID-19 vaccine update for people with CF. The CF Foundation and all of us on your care team support vaccination for all people with CF and their family members who are eligible. All 3 authorized vaccines have been shown to be safe and effective, especially at preventing hospitalizations and death. Side effects have been rare and minor for most people.
Hey everyone, I am Morgan Green and I'm one of the physicians with the Adult Cystic Fibrosis Program, and I'm going to be talking a little bit about lab studies that we obtain on everyone. So the first test is I want to talk about is called a CBC. It's very common, complete blood count, and the main things that we can tell from a CBC are information about white blood cells or WBCs, and the components of and different types of WBCs, including neutrophils, lymphocytes, eosinophils, and those can help us know if someone is fighting an infection. And the other thing we can know is platelets, and platelets we want to be in a normal range. And the other thing we can know from a CBC is about anemia. Hemoglobin and hematocrit make that up. And so we want to make sure that all of these are within a normal range and that they're the appropriate level that we would expect for someone to be healthy. Another one is called CMP, or Complete Metabolic Panel. And this looks at chemistry of the blood, electrolytes, which include sodium, potassium, glucose, protein, acid, and base. And it can also look at how well your kidneys and liver are working. So very important to know that all those things are remaining normal. And the other thing, of course, we check is something called fat-soluble vitamins. The fat-soluble vitamins include vitamins A, D, E, and K. And of course, many folks with CF take DECA vitamins, and that's where we get the DECA comes from, D-E-K-A. And folks with CF are at risk for being low on these because these vitamins don't absorb as well through the GI tract of someone with cystic fibrosis. So what we can do is check blood levels to see how those levels are doing in the body and see if we need to increase vitamin supplementation to try to bring those back into normal range. So another thing we of course like to do is the oral glucose tolerance test. Is probably the least enjoyed of the many lab tests that we do, and so we appreciate everyone with CF putting up with it because it's not fun. So what we find from this is looking at cystic fibrosis related diabetes, or CFRD. So an oral glucose tolerance test can be done also to detect type 2 diabetes or gestational diabetes, and so that's used outside of the field of cystic fibrosis as well. So how it's done, and many cystic fibrosis patients have done it before, is we check a fasting blood sugar, and we'll have the patient drink a sugary solution that doesn't taste all that great, and then check a sugar after 1 hour, and then check it after 2 hours as well. And we want to see if the body is metabolizing that sugar appropriately. And if the sugar is high after 1 hour or 2 hours, it can be the indication of cystic fibrosis related diabetes. And that we would definitely want to know about and be watching over time. Another test on this slide is called total IgE, or immunoglobulin E. And so this is an antibody. Our bodies are filled with antibodies of a variety of kinds, but this one is important because it can be elevated if someone is having an allergic reaction to something. And one specific allergic reaction we worry about with cystic fibrosis is called allergic bronchopulmonary aspergillosis. And what that is a body's hyper reaction to a fungus called aspergillosis. Aspergillosis is the name of the condition. So we check this IgE level to make sure that it is normal. And if it is elevated, we might be concerned for this disease called allergic bronchopulmonary aspergillosis, or ABPA. So that's something we check on everyone each year with cystic fibrosis. So another test we are able to obtain is called hemoglobin A1C. So what this is a test for diabetes as well. So it looks at the amount of glycogen, which is a type of sugar that is stuck to a red blood cell. So our red blood cells are circulating through our body all the time, and one red blood cell lives about 90 days. So this is able to tell us how much sugar has been circulating and getting stuck to that red blood cell for the last 90 days or 3 months. So it's a way to also evaluate diabetes. And it raises the question, why don't we just do this to diagnose someone with diabetes instead of doing the awful oral glucose tolerance test? And that's a really good question. And to that, I would say the problem is that individuals with cystic fibrosis have a higher turnover of their red blood cells from those without cystic fibrosis. So the hemoglobin A1C does not give as accurate a picture of the amount of sugar circulating compared to the oral glucose tolerance test. But where it is valuable in cystic fibrosis is to see if diabetes is worsening and if it is controlled. One more thing that's measured also every year in individuals with CF are called clotting factors. And so we usually call these by their abbreviated names, INR, PT, and PTT. And what they all are measures of the blood's ability to clot. And obviously, if someone is not able to clot as well as they should, they could increase risk of bleeding, and that's something we certainly don't want to have happen to people. So that's something we check every year to make sure that they're within normal range. And so we always appreciate everyone with CF getting these labs done every year, because it helps us keep them safe and keep a good eye on things going on inside the body at all times.
Hi, I'm Zach Holliday, and today I'll be talking about diagnostic testing in cystic fibrosis. So we kind of split diagnostic testing up into two categories. One is our yearly, what we'll call maintenance imaging, and the other is symptom-based imaging. And per CF Foundation guidelines, they recommend getting some sort of chest imaging at least once a year, whether that's a chest x-ray or a CT or CAT scan of the lungs. They additionally recommend doing a liver ultrasound every year to monitor for new or progressing liver disease, and a DEXA scan either every 2 to 4 years, 5 years, or more frequently, again, depending upon the degree of bone disease. And what we're looking for there is, again, early progression or following progression of osteoporosis or osteopenia. Now, we also do symptom-based imaging, and that's when somebody comes in with increased respiratory symptoms, whether that's a cough, sputum production, feeling more short of breath, or abdominal pain. We might get an abdominal x-ray to look for things like bowel obstruction or infection. Pulmonary function testing is another maintenance test we do to follow lung disease and lung progression. The testing usually begins around age 4, as before then it's difficult for children to follow the coached instructions to perform a pulmonary function test. What we look for there are many different variables, but the most common variables that we follow or we trend are the forced expiratory volume in 1 second, or FEV1, and forced vital capacity, which is the total amount of air that someone can breathe out. Why we trend these numbers is it can help us track the degree of lung obstruction, lung disease, or maybe even diagnose acute infection. And these numbers are really important to follow, as sometimes they can trend down even before a patient develops symptoms and may trigger a provider to recommend increasing therapy, a change in therapy, or even an inpatient stay. But what if my numbers are down? Is that just because my disease is worse? Is that because I'm sick? Well, that could be it. But there's other things that can affect your testing as well, whether it be mood, whether you're tired, maybe you're just full from eating. And then lastly, again, kind of combining all those, if the effort's not there, sometimes those numbers can be down as well. One thing that we've started since the pandemic is using home spirometry more, and the most commonly used one right now is Zephyr RX, and that's because the company was nice enough to help out the CF Foundation and in providing devices for most patients to use at home. And these are great tools to have, both to monitor symptoms on a daily basis, but also to be able to monitor when symptoms are worse and whether or not someone needs to come in. And they can trend close to your in-person or in-house spirometry in a hospital setting. But more importantly, it's a good use, I think, as a trending tool.
Hi everybody, it's Natalie Harris, respiratory therapist here with the Pediatric and Adult Centers at the University of Missouri in Columbia. Let's talk about keeping our treatments on point. First way to start this is to make sure that we're doing our inhaled medications in the proper order of therapy. Let's start with our bronchodilator to open things up and make sure we've got the largest working channel we can. This would be your albuterol, your levalbuterol, or your ipratropium. Next, we move to our airway hydrator, which is hypertonic saline. You might know it as Hypersal or Pulmosal, but either way, it pulls water into the airway so the cilia can stand up and do their dance. Next is our mucolytic, which would either be Pulmozyme or Mucomyst. These medications break down the proteins that are in mucus to help thin it out and let it get moved along. Those things we can do during our airway clearance. And once it's done, that's a perfect time to do your inhaled antibiotics, also known as your germ killers. They get in and kill bacteria. So that's either your Casein or your Chole, maybe Toby or Aircase, or potentially some other medications. Last thing you want to do is your inhaled corticosteroid or combination medication. These are medications that get in the airway and hopefully decrease any inflammation that's in there. This could be Flovent or Advair, Dulera, or Pulmicort. Next, we want to make sure that we are making our airway clearance as active as we can. How about you make sure that you're doing your airway clearance, not letting it be done to you? Important things. Do your best. Don't just sit through it. Don't zombie zone out on me. Let's make sure that we are deep breathing and getting coughs in there. What kind of cough? A huff cough. So make sure you get that big deep breath. Hold it and then make that H sound, okay? Also, it's important to check your tubing and your hoses and your vest jacket every month or so to make sure that there aren't any holes and that your voice is getting that vocal interruption or shaking like we always like. Make sure that you're also cleaning your oscillatory PEP devices. What is an oscillatory PEP device? Well, that can be either your aerobica or your acapella or even an IPV. Make sure that you're cleaning those between treatments. Also, important for everybody, CF and not CF, is making sure that you get 30 minutes a day to get some active time to get air in and out and get that heart rate up, because it's good for your heart, your lungs, your muscles, and your brain. So let's make things active. Keeping your nebulizer cups clean at home is the last thing you can do to make sure that your treatments are kept on point. You can use either hot methods, including boiling for 5 minutes, steam sterilizing, putting in a steamer basket or a steamer bag in the microwave, or using in your dishwasher, as long as you can ensure that it gets up to 158 degrees Fahrenheit for 30 minutes. You can also use cold methods, such as soaking in 70% isopropyl alcohol for 5 minutes, or soaking in 3% hydrogen peroxide for 30 minutes. After both of these types of soaks, you have to make sure that you rinse with sterile water, which you can either purchase or can be made by bringing water to a rapid boil for 5 minutes and then allowing it to cool. All of your pieces and parts need to be air dried, either on clean paper towels or on a drying rack before you store them. But make sure that you are not using vinegar, bleach, or any type of Control 3 type solutions to clean your neb cups. Vinegar will not kill CF-related germs like we need it to, and the other two could potentially be damaging to your cups or to your lungs. So keep those methods simple, but make sure that they're effective.
Hi, my name is Zach Holliday, and I'm one of the Adult Center Co-Directors here at the University of Missouri, and today I'm going to be talking about the COVID pandemic has affected research projects throughout the U.S. and across the globe over the last 1 to 2 years. Despite the limitations from the pandemic, CF research has continued, and that's really thanks to the patients who have been willing to participate in research projects. Without the patients, we wouldn't be able to make advancements in therapies and treatments. Now, if you're a patient who's interested in research, how do you get involved? And there's 2 easy ways to get involved. The first is just ask your local CF center about opportunities to be involved with research, whether that's at a local level or a national level. That may involve going to a different center. It may involve coordinating through your own center. But either way, ask them, and then they can help get you in the right direction if you are interested. The other way to look for trials is to look at the clinical trial finder on the Cystic Fibrosis Foundation website, and that's at www.cff.org/trials/finder. On the website, there's a list of all ongoing trials, as well as previous trials that have either completed enrollment or have data that can be viewed by the public. Now, in previous community chats, there's been discussion about national trials of Mayflower's Promise, Simplify, looking at outcome measures after starting the newest modulator, Trikafta, as well as looking into simplifying, as the name implies, simplify, airway clearance regimens after starting Trikafta to see if we can reduce the burden on patients by reducing their daily regimens. Now, the Simplify trial was looking at evaluating withdrawing either hypertonic saline or DNase, trade name Pulmozyme, from airway clearance regimens in patients who have started Trikafta. Here at Missouri, we're looking at our own patient cohort and their interest in reducing airway clearance regimens. As part of this evaluation, we're using MRI ventilation perfusion scans to see if stopping therapies have an effect on imaging, as well as daily symptoms and changes in pulmonary function testing. One trial that we're hoping to get off the ground in the next year is actually looking at completely stopping airway clearance in a cohort of patients who've got mild lung disease after they've been on Trikafta for over a month. Now, a lot of the recent research has been looking into restoring the CFTR function, that cystic fibrosis transmembrane regulator function. And the current drugs in the market, ivacaftor has now been approved down to age 4 months. Trikafta has been approved down to age 6 years. And they've got ongoing studies, again, that are listed on the CFF clinical trials webpage, looking at individuals with the G542X mutation, as well as other newer modulators that are currently in the pipelines for development with open enrollment, even for patients who are currently eligible for Trikafta. Now, there are other centers in our area who also have ongoing studies. That includes at the University of Kansas and St. Louis University in St. Louis. What they're looking into is evaluating lung function decline in folks with CF-related diabetes. They're looking at certain pathways to see if they affect modulator efficacy. They're looking into improved delivery of inhaled antibiotics, as well as looking at oral diabetic agents as a replacement for mealtime insulin in individuals with CF-related diabetes. Most important is patient and family input. Care centers are always looking to collaborate with the community to get their input about what topics should be explored next in research that will have the largest
Oops, that looks like that was an abrupt ending. But we definitely want to thank our Columbia Care Center team. If you guys want to turn on your videos wherever you're at to say hello. We've had some people hop in and off of this call. But I will tell you, for me, it was just wonderful to see all of you in person. It's been a long time since we've had the opportunity to be together in person. So it was wonderful to see your team and to hear what's been going on. I know a lot of the mental health and honestly some of the dietitian pieces were just helpful for people in general. I read something today that, you know, instead of the freshman 15, it's the pandemic 29 with some average weight gain. So I think for mental health and some of those other pieces, it was just really applicable to our entire community, the care support team for our CF folks, but also for our CF community as well. So I want to open it up to questions. If you have anything to go into the chat or anything, folks that are online, if you want to type it into the chat or into the Q&A area, I'm monitoring both of those. But from our care team, you know, you've recorded this and you've done a really great job, but, you know, over the past, we say 18 to, 20 months, what is probably the biggest thing or the most repeated question that you've gotten that you've had to either talk to parents or your CF community about that you just want to reiterate the most?
Yeah. Let's see. There we go. Let's see.
Oh, looks like a party. I love it.
Yeah, we're all kind of
so most common question.
It's probably so much about safety coming back to clinic, I would say, is, and I would say that all health systems everywhere have been, discussed this to an incredible extent and to ensure the safety of everybody with and without CF coming to clinic, being hospitalized. Very early in this, I think people would say to me, if someone would say, oh, I can't go to the ER, there's COVID in the ER. And I would try to say that everyone with suspected any respiratory symptoms were being triaged, so evaluated immediately and kind of put in isolation, or and all the precautions were being taken to treat everyone, no matter the condition, in the ER and no matter the symptoms. And so I would say that that is still true as we've gone through all this, to try to ensure that everyone is safe in any clinical setting. If you need to be hospitalized, then the hospital floors are safe and precautions are taken. If you need to be seen at clinic, then in clinics, precautions are taken, and that's still in place today.
I think along the same lines is can we keep doing telehealth? So, I think that's become a big portion of our care now is doing some of the care in telehealth. And we know that we can't do some of those things that we talked about in the slides via telehealth. We can't get those labs. We can't sometimes get the spirometry or imaging. But there's other times where I think the telehealth has been a good resource, especially for our patients who have limited funds and who have a difficult time driving from hundreds of miles away to clinic. So that's been something that's been brought up a lot. And I think we're utilizing a lot better than we would have before pandemic.
I think, sorry, one of the common questions I think that we get on the pediatric side, and I think it probably overlaps some with questions that that the adult patients may bring, because the adult parents ask us also about the safety of being back in school, the kids being back in school or with activities. And as parents, many times their questions were about whether they should be at work themselves, or whether they should have an exception for being exposed and working remotely. So I think that was something that we answered a lot. And I think the message there was, trying to follow the level of activity of COVID in the communities, and following the recommendations as the pandemic unfolded, and the understanding and the recommendations from the CDC and other, bodies of authority that helped us counsel patients and families in that manner. So I think that was something that was very much on the mind of our parents, balancing the desire to have kids in school for all of the benefits of socialization and staying current and being able to succeed in school while minimizing their risks for infection.
Great, thank you. And I guess
to that, like what you were saying, balancing the safety and the mental health. We saw that a lot, especially as people were going back to school and parents were worried about their kids getting COVID, but they were also failing in school or socially struggling because they weren't seeing their friends and their peers. And so we dealt with a lot of mental health, including on the pediatric side. You'd probably be surprised at how much it truly affected people of all ages.